All right, everyone. So we're starting the session, and I'd like to welcome you all for tonight's session in Surge Kuwait. For those newcomers, Surge Kuwait is an organization that's dedicated to delivering education regardless of our geographic borders. And it's an online platform. And you can always follow us in our social media, such as Instagram and Twitter. So for tonight's session, we have Dr. Alexander Lee, and he's a thoracic surgeon at Vancouver with a presentation on management of GERD. And just as a quick reminder for everyone, for any questions that you may have, post them at the Q&A panel that's going to be available at the bottom, and all questions will be answered at the end of the session. So I'd like to welcome you, Dr. Alexander Lee, for his presentation for tonight, Management of GERD. Management of GERD, Dr. Alexander Lee.
Thanks a lot for the introduction, Dr. Omar, and it's a real pleasure to be here with you tonight. And also, it's a pleasure to be in the final month of training Dr. Isa Algonem, who's going back to Kuwait as a thoracic surgeon and a graduate of our program. So it's a real honor to be with you tonight and this morning. And I know Dr. Isa is with us online too, I do believe.
The honor is ours, Doctor, and the pleasure is ours.
So we're going to chat a little bit about reflux and hiatus hernia. We're not going to cover motility disorders today. And you can't really talk about reflux without talking about hiatus hernia. And it's occasionally the same topic, but sometimes not. So reflux, I think we all know what reflux is. And sometimes it can be difficult to decide, is this reflux or something else? So what exactly is gastroesophageal reflux disease? Now, I think of it in terms of a clinical problem, and we commonly think of it just as a gastroenterology issue, but really we often get referrals from respirologists because of airway complications. So we commonly think of heartburn, odynophagia, but people also can have reactive airway disease and frank aspiration. So commonly we do procedures specifically for their airway manifestations. At endoscopy, there are people that have very minimal symptoms, but they have atrocious esophagitis when you do a scope. And what we're looking for is esophagitis, erosions, ulcerations, strictures, and metaplasia. And we know what metaplasia is, but we are worried that there is a continuum of metaplasia to dysplasia and then adenocarcinoma. So that's why there are recommendations to screen people with Barrett's esophagus. So what causes it? So, when I was a medical student, I thought it was just an increase of acid in the stomach, but it's more than that. So if someone has a loose lower esophageal sphincter, then stuff in the stomach, be it acid or food or bile, can come up into the esophagus. Now, is this looseness all the time or transiently? Sometimes you just don't know. Is the hiatus loose? Now, the hiatus should act like a sling on the lower end of the esophagus. Not too tight, not too loose, but just enough to put a little bit of external pressure on the lower end of the esophagus, right at the lower esophageal sphincter zone. And the purpose of the hiatus really is to hold the lower end of the esophagus in place. And quite honestly, the stomach should be in the abdomen and the esophagus should be in the chest, but part of the esophagus should actually be in the abdomen. So a hiatus hernia can cause reflux, and this really means that there's no abdominal esophagus. The esophagus should be 2 or 3 centimeters in the abdomen exposed to positive pressure in the abdomen, where in the chest it's exposed to negative pressure, just like when we breathe. So if the lower end of the esophagus and the stomach is in the chest, well, there's a tendency to open things up because we breathe with negative pressure, as opposed to that lower end being in the abdomen pressed down because of positive pressure in the abdomen. And yes, there's too much acid and delayed gastric emptying. So if people feel a sense of bloating and nausea after they eat, they might have a delay in their gastric emptying. And this is commonly seen in people with diabetes. And certainly when we are contemplating redo surgery, I'm very concerned about gastroparesis in the setting of prior surgery and vagal nerve dysfunction or damage. So this is how I think of what's causing someone's symptoms. What are some of the tests? Now, a barium swallow is not just a one-sentence final conclusion. You're looking at a lot of things when you're doing a barium swallow. So what I want to see in the report is I want to see a comment on, is there any aspiration with the first swallow? Is there a sense of peristalsis? Is the esophagus dilated in any way? Is there clearance of the contrast to get into the stomach without there being an obstruction? And is there any reflux? Meaning with peristalsis of the stomach, do you see reflux? And how high does it go? And sometimes people will say on the report, there's a small amount of reflux, or, oh, we saw reflux all the way up to the top part of the esophagus when we did our test. And sometimes it could be very dynamic how you do the swallow. It could be in the upright position. And if someone is having potential symptoms at night, sometimes if we get some images where they're on the supine position, that'll give some good information. Endoscopy, again, it's not just seeing specific things. You're trying to get comments on the physiology too. So when I put the scope in, yes, I want to see, is there any damage? I want to quantify the esophagitis. Is there a stricture? Is there any bleeding? What's happening at the hiatus? And I do like to comment on, well, I didn't see much peristalsis. When you put the scope in, the esophagus is supposed to contract around the scope. It thinks it's food. And if you don't see that, then it's a hint that there might be some kind of motility problem. Also at endoscopy, I want to get a sense of what the lower esophageal sphincter is doing. So I'll always just sit my scope just above the GE junction. Yes, I'll comment on the damage and things, complications of reflux and describe bearers, but I want to get a sense of what's happening at the lower esophageal sphincter. And if I put the scope right there with very minimal insufflation, and I could see right into the stomach, then clearly there's looseness to the lower esophageal sphincter, to the hiatus itself. And commonly, if a person is a little bit under anesthetized and they're retching a bit, then I commented on, is there any acid coming up? And if there's so much laxity and looseness to that whole lower esophageal mechanism, sometimes people, even with retching, rolls of stomach come into the esophagus. And no medication is going to help with that. Gastric emptying study, if I do think that there is some element of gastroparesis, or they may be predisposed to it, such as someone with diabetes, connective tissue disorder, or if I've had a prior surgery at the GE junction, then I commonly order that to get a sense of, hey, is this the real culprit? And there's motility tests and pH tests. So a 24-hour pH study is where a probe sits in the esophagus over 24 hours and it measures the acid content, and there's a scale to that. Esophageal motility is a test where a probe is put into the esophagus stomach and needs to be positioned perfectly. And then with 10 swallows or more, you get a sense of what is the esophagus doing in terms of peristalsis and lower esophageal sphincter function. So people always ask me, when do I actually order these tests? So if someone has significant symptoms of reflux, someone does an endoscopy and you see obvious damage from reflux, I think we know we've got a diagnosis. So in that situation, I commonly don't do a 24-hour pH study. If someone has dysphagia, on top of having reflux, and I'm not sure what's really going on, or if any other previous studies give me a hint that there might be an issue with motility, I usually get a motility test. So I'm more likely to get a motility test than a 24-hour pH study. And sometimes you just can't do these tests when there's a giant hiatus hernia, or someone who's got severe echolasia and a massively dilated esophagus, or if there are other issues to the esophagus, like a diverticulum or something else. So I tend to use these tests judiciously. It's not a mistake just to order them on everybody. They're pretty low risk tests, but bearing in mind that sometimes all these tests don't correlate. And then you have to use your own judgment to decide, well, what should I do in this situation? And as a surgeon, I used to get a lot of referrals from family doctors, and I still do. I think nowadays I prefer them to have a first pass through a gastroenterologist to get a diagnosis, to be worked up. And then, hey, look, we decide together if we want to do an operation for reflux. And the reason why I say that is that the results for surgery for reflux, they're not 100%, and they are a surgery, and that surgery should carry a 0% mortality. And in North America, that's not the case. And even in my hands, I do have to quote a number of success, being able to be off PPIs. You have to come up with a number for an individual person, and we'll chat about that a bit later. So again, we chatted about the reflux progression. There's reflux, there's Barrett's, dysplasia, and what we're trying to avoid is getting to that point. And there's different strategies for each. You know, what do you do for Barrett's? There's screening programs. What happens if biopsies show low-grade dysplasia? Well, that means you increase the PPI, lifestyle modification, and rescope. High-grade dysplasia is very worrisome for occult carcinoma in situ. So this is where we're getting into very complex scenarios. And therapy could involve ablation and anti-reflux surgery, or it could involve a full workup for cancer, and then you find some, with or without doing very advanced biopsies, not just biopsies through the scope, but mucosal resections and dissections, so-called EMR, ESD. So what's the standard for therapy for reflux? Well, there's the lifestyle stuff. And as a general rule, I tell people, well, you know, you can look online, we have pamphlets, but whatever is good for the heart is good for heartburn. So exercise is a good thing, avoiding alcohol, fatty foods, peppermint, coffee. You know, I have truck drivers who have 10 coffees a day and don't do any exercise, this kind of stuff. So you want to encourage lifestyle modification. It can be very challenging in someone whose predominant symptoms are respiratory, who may be on prednisone. So then you just have to bite the bullet and do something about that. But for the most part, you do want to encourage lifestyle modification. Medications, this makes sense. There's antacids. And, you know, if I come across a person who is going to be declared refractory, I usually put them on Dexilant, high dose BID, and a prokinetic, and some topical stuff like Malox or whatever, and then we see what happens. And if they're still having symptoms and they're saying, look, I just can't live this way, then we think about an operation for sure. And certainly if someone, despite all these medications, have severe damage on the inside and or they have low-grade dysplasia, I am really thinking about, I think we need to do an operation here. So this is a study that came out in 2019, randomized trial, you know, one of the more recent good trials. It's in the New England Journal, looking at medical versus surgical. And I don't want to go too much into this because this will be one of our journal club topics to analyze how they actually did it. It's a VA study, men and mostly. And bottom line is, after all that, in a big surgical study looking at 78 patients, I found that with surgery for refractory heartburn, surgery had a higher quality score. And this makes sense to us. And, do we think about this in terms of, hey, yeah, we should be doing surgery? I think of it as a continuum. And I like to work with the gastroenterologists in situations where, like, we're just not sure. And what do you think? It's always good to have collaborative effort when it comes to this type of thing. I'm going to see if I can answer the question. I'm not sure if I can. I can't really do it. Either way, I can't open up the Q&A. So anybody wants to jump in, please do. Or maybe Dr. Omar could help with some questions. You have to be very mindful that there's a condition called Eosinophilic Esophagitis. And this is an immune situation. Type 2 T helper cells are involved. And it's in response to food and allergens. So in someone who has pain and you do a scope and don't really see much, and you're wondering, is this reflux or not? And you are going to come across people that have classic chest pain, and you do need to rule out, is this a heart thing? Is it a chest wall thing? Is it a motility problem? So this is where I like to remove myself from that type of investigation, because as a surgeon, I do surgery. And once it gets very complicated, I would rather have one of the expert gastroenterologists try to sort out what the problem is. And I think everybody has to know their own limitations. Specifically for eosinophilic esophagitis, you treat this with steroids, either oral or inhalant steroids. And here's some picture that I wanted to show you. On the right, labeled B, that's what eosinophilic esophagitis looks like. You don't really see much damage per se, and you see this kind of ringed appearance. And you do biopsies, and if there's a certain amount of eosinophils per high-powered field, 15 or more, then that's the diagnosis. If you take a look at the picture on the left, I think most endoscopists would say, hey, there's really bad reflux here. There's esophagitis, there's bleeding, erosions, and there's a hiatus hernia. But I would like to comment on the fact that the GE junction proper is wide open. It shouldn't look that way. In a normal human being, it shouldn't look that way. Moreover, there's a couple centimeters of a hiatus hernia, and you can see, if you increase the light, then you can see right into the stomach beyond that. So this is an ultra loose lower esophageal sphincter. And oftentimes the endoscopist doesn't report on that. So again, you want to get all the information that's readily apparent. Normally, when we eat and drink, we should be able to do that hanging upside down from a tree. And I say this because against gravity, the esophagus should propel liquid and solid against gravity to the stomach, and it should stay there. It shouldn't immediately pour out. So the patient on the left, that would be a problem. And, if someone golfs or ties up their shoe, I often ask, hey, after a big meal, if you were to tie up your shoe, do you have a sense of acid reflux? Oh yeah, I vomit in my mouth. And then, okay, that person probably needs an operation. So what is the surgery that we do? Now, who do I look at? Who do I think is the best results? Well, someone who's optimized and motivated. I think that should be obvious. It's not a perfect operation. No or small hiatus hernia. I say this, and it's not so much about the hiatus hernia per se. It's really about, well, what's the hiatus tissue, and are my sutures at the hiatus going to hold, or are they going to rip apart? And how much of a dissection do I need to do to bring the stomach out of the chest? And what's the likelihood there's going to be an anatomic recurrence, which likely means recurrence of symptoms? Normal length of the esophagus. This is a big thing, or is it? There is a concept called the short esophagus. And indeed, if someone has an anatomic short esophagus, congenital situation, then sure, it's short. But for the most part, the esophagus doesn't shrink. People think that sometimes the esophagus shrinks this way with prolonged amount of damage. Certainly when someone has a hiatus hernia and the stomach has moved up, does that necessarily mean the esophagus is short? I don't think so, because when you do an endoscopy on someone with a big hiatus hernia and the GE junction is above the hiatus, you get this accordion, tortuous appearance. And if you were to put a bougie in it and mobilize it completely, I think most of the time, in fact, almost all the time, you can get the esophagus straight with the lower end in the abdomen. When we do endoscopy, I always look at where is the hiatus and where is the GE junction. And that'll tell me how easy the operation is going to be, really, when I do hiatus hernia operations, in the sense that, well, how much mobilization do I have to bring down? So anatomically, for most people, the GE junction should be around 40, same as the hiatus. Technically, the hiatus should be at 38 and the GE junction should be at 40, meaning there should be a 2 or 3 centimeters of the lower end of the esophagus and the stomach, as we chatted about earlier. Okay. I do want to make sure they have good peristalsis and no dysphagia. And if they do, and there's a question of poor peristalsis, then we start thinking about doing a lesser wrap, a floppy wrap, not making it tight. And then these people are predisposed to having recurrence of symptoms. So what is the operation? The esophagus goes through the hiatus, and the hiatus might be loose, so it needs to be tightened to some degree. If there is a hiatus hernia, that needs to be fixed. And again, what's the big deal about fixing a hiatus hernia? Well, yeah, they could be at risk of having herniation, strangulation, etc. But really, the real key here is to bring the lower end of the esophagus into the abdomen, so it's exposed to abdominal pressure. And then some type of flap valve. So the valve, as I often call it, or fundoplication of some kind, is really there to put a bit of pressure on the lower end of the esophagus. But then that pressure should be such that it doesn't obstruct the passage of food. And ideally, it should keep liquid and solid in, but should also let a little bit of air out. Because if it doesn't, then the patient gets air trapping and gas bloat, meaning a lot of air swallowing and a lot of flatulence. Okay, abdomen versus chest. I get this a lot. If it's an abdominal approach, that's my preferred approach. And despite being a thoracic surgeon, my preferred approach is abdominal and laparoscopic. Certainly, if it's a redo of my own, I'm pretty successful at doing redo laparoscopic surgery. If it's from someone else, it's likely that it may not be as successful. So I usually quote a higher open rate. And the key to that is I always ask the patient, if I'm doing someone else's reoperation, hey, how'd the first surgery go? And if they said, oh, I was in and out the next day, then probably I could do it laparoscopic. If they tell me, oh, I was in hospital for 2 weeks and it was terrible, then probably there's going to be a lot of adhesions. So that's just some rules in my own mind. A chest approach, I can't imagine doing this video assisted. It's just too complicated. And yes, there's some people out there that say they have or whatever, but it really is an open approach. What I commonly get is if someone has had a prior abdominal procedure and there is a recurrence of herniation, I'll get the referrals saying, oh, well, I'm giving it to you because, they've had prior abdominal operations and maybe you can do it through the chest. Well, if you think about it, a big hiatus hernia, if there is one, it involves 2 cavities, the chest and the abdomen. So in the situation, if someone's had a prior abdominal surgery, the chest is virginal, but the scarring in the abdomen may make it such that I can't stuff it down there. So it's not always possible. And there have been times that I've actually done a two-field chest and abdomen redo hiatus hernia operation, which is not pleasant actually. So specifically for reflux, the surgery would be an abdominal approach. And certainly if there was no hiatus hernia, I don't think you would do an anti-reflux operation to the chest. So you would only do a chest approach if in fact there is a hiatus hernia. There's a very simple picture. Everybody knows what a Nissen fundoplication is, but this is what's in a textbook. And I want to draw your attention to how the picture is done here. So if you look at the lower picture, you see the fundus wrapped around. And I call the thing on the right, or anatomic left, but the anatomic left part, the anterior limb, and the part that's wrapped around is the posterior limb. And quite honestly, the pictures are always drawn this way with the sutures right at the front. And I don't like this because the anterior limb is 1/3 and the posterior limb is 2/3. And there's a tendency for that to corkscrew, to rotate, which could cause a bit of an obstruction to a patient. So I like the both limbs to be 180 degrees. So the suture line is a little bit more to the anatomic right. So when I do these operations, I anchor the fundus to the lower end of the esophagus. So to maintain the lower 2.5 to 3 centimeters of the esophagus in the abdomen. I've done my crust stitches all with O-silks. So I like to O-silk and hand do it rather than using the, I forget the name of the thing, the Ethicon suturing thing. So I do interrupted silk to bring the crust together. I do the fundus wrap, and then I anchor the wrap to below the diaphragm. So what this picture doesn't show is the sutures to the hiatus, and then sutures to the fundus esophagus and the hiatus. So it's like a doorstop. So I do that for hiatus hernia, and I do that for anti-reflux surgery as well too. So again, there's some thoughts on all this. So let's take them in turn. What's the degree? How much do you do a 360 as in Nissen? Do you do a 180, 240, 270? I think there were some papers out there suggesting that maybe a partial wrap might be better to avoid dysphagia down the road. I think you have to use your own judgment. There's no real evidence to say one way or the other. I personally believe that Nissen is the best way, a full 360, unless there's some issue with peristalsis. To position, we talked about it. I don't like it to be right at the front. I want it over to the right so that the anterior and posterior limb are equally matched, so there's no rotation. The length, I like it to be about 3 centimeters in length. Bougie size. In the olden days, I used to put a bougie down. Now I don't. Bougie is supposed to simulate the size of like a food particle. And the way I size the wrap itself is, well, can I stick a finger underneath the wrap or one of my instruments? And if it's looking too tight and I have to hold it just to suture it, then that's going to be too tight. And specifically at the hiatus, I size that. I used to size it with the bougie in and also with the bougie out in the flaccid state. And with the esophagus and the hiatus, you should be able to put a fingertip. And, the size of a laparoscopic grasper is like a fingertip. So I spread it. Oh, that's about a fingertip. And again, none of these things are perfect assessments of your repair. And I'll be the first to say that I've had patients that have had reflux right away. I've had patients that couldn't swallow their saliva. So again, sometimes you just get it wrong, despite a good surgery. I tend to take the top part of the short gastrics down, not all of them, just so I can have the wrap free of any tension, because I don't want the stomach to be pinned over to the side, pinned over to the spleen. And I'd rather divide the short gastrics with an energy device rather than ripping them by accident anyways. So as a general rule, I take down the short gastrics. And if I am thinking about a redo procedure where I do think that there's gastroparesis causing the situation, I'll do a gastric emptying study prior, and then likely do some type of outlet procedure, and usually a pyloromyotomy. It's kind of obvious when you put your camera and there's this giant stomach. It's like, oh, that guy's got gastroparesis. So again, one can do incomplete wraps if there's some element of dysmotility. So there's the door and the front door. That's how I always remember it. And the posterior toupee, not me. And here's just some pictures of that. So the Nissen, again, I like the sutures a bit more to the other way. The door is commonly used when you're doing that in addition to echolasia surgery, and the posterior toupee. And with echolasia surgery, I've done both the door and the toupee, just to show our trainees that both are good. I would never say that one is better than the other. Sometimes you just can't get around the esophagus and proximal stomach in a redo operation. And yes, Dr. Iesa will tell people that there have been times that I've perforated the esophagus and the stomach in a redo operation. You know, that's just that's the nature of the beast when you're doing second operation, third operation, fourth operation in. Maybe I should just do a gastrectomy. The thoracic approach is called the Belching Mark IV, but the Belching approach. And this is hard to imagine if you haven't seen it. So this is done through the chest, and you know, you can do a 360 Nissen through the chest, but this was designed prior to that thought process. So it's like a 3/4 wrap or a 2/3 wrap. And this is somewhat challenging. So this is when there is a hiatus hernia. So you wouldn't do the Belching operation for reflux per se. So this is a funny picture where you're in the thoracotomy position at the back. So what we're seeing here is a snare around the esophagus, and the aorta is there too. And the sutures at the back are the hiatus sutures. So if you think about it, oh yeah, that's exactly where it should be, because the teardrop of the hiatus from the abdomen would look that way. So you're doing everything backwards. And then rather than wrapping the esophagus, the stomach around, you're kind of intussuscepting it, which makes a functional wrap. So this is where you have some sutures in the esophagus, then the hiatus, and it rolls it on, and then you stuff the whole thing underneath the diaphragm with more anchoring sutures. It's kind of a cool operation, actually. And it looks something like this in a cross section. So here's the problem when you have the short esophagus. And I think we're going to leave this for the hiatus hernia discussion, which we'll do separately. We'll just go back. We'll skip all this stuff. So the surgery, most of the time, should be laparoscopic. The mortality should be 0. It should be a very short operation and a quick stay. Some people in the States get people home that day. You know, I'd like to observe them overnight, get them home the next day. And some people need 2 days, but the recovery is pretty quick. Yeah, this is not good. Like, this is what I tell people. And I do a lot of these operations. So, you know, when you say 70% are going to have a good long-term result, I err on the side of, you know, pessimism. In cardiac surgery, I worked with a surgeon that would tell patients before an aortic dissection that all these patients are going to die. And then when he gets some living, then it's a surprise. Oh, thank you, great doctor. Thank you, great doctor. So I think it's good to be pessimistic about the results. You don't want to say, we're going to have a perfect result, because then you're going to have a lot of unhappy patients. So you do have to set expectations appropriately. Side effects could be dysphagia, you made the wrap too tight, or that's just them. Gas bloat, worsening of irritable bowel syndrome. You know, I often call it, and I made this up myself, irritable bowel of the foregut, because we're operating in and around the vagus nerves that can lead to poor function of the stomach and then downstream effects. So that is temporary. And yes, sometimes I've made it too loose or too tight. I've done about 600 of these operations, and there was once that the patient couldn't swallow his own saliva post-op day 1 and 2, so I did an immediate revision. Redo surgery, results are not as good, more likely to need a laparotomy, and more likely to have 1 or 2 vagal nerves damaged. And adhesions can be very significant. I'm amazed at how the liver can just glue down on top of you, and you spend a lot of time getting that off. And let's not forget there's other structures like the porta and the cava. Heard lots of times people injuring the cava of all things. And I've got a hiatus hernia patient that had a prior liver resection, and I'm kind of scared about a liver transplant. And I'm kind of scared about that operation. So, you know, adhesions can be significant, and they often need a gastric outlet procedure. And this is where sometimes thoracic surgeons start getting into gastric bypass for these patients, because they've had such grief at the GE junction, the stomach doesn't empty, and no outlet procedure helps. And then you sometimes have to do a gastrojejunectomy just to improve the foregut function. Bottom line, you need to be very selective, do a good operation up front, be open about the results. And again, as far as I do the repair, it's not just the wrap, it's the hiatus repair and then anchoring things below to maintain all of the anti-reflux mechanisms. So we're going to chat about hiatus hernia now. And a lot of what we chatted about already is what part of this, but we're talking about anatomic variants now, okay? I think everybody knows what the differences are: type 1 sliding, type 2 para, 3 combined. And really the most important thing is, where is the GE junction at? Is the GE junction above the hiatus or below? And in many ways, type 2 parasophageal is the easiest, because you don't have to do a lot of esophageal mobilization. So I think we know this. There's the sliding and then the parasophageal. And then when I look at risk, I get a sense of, well, what is the defect and what's the content? So think about that for a bit, and then you'll get a sense of, well, what's the real risk of a serious complication? So we'll chat about that a bit more. So it's always good to know your anatomy and distances of things. And you need to know this for cancer of the esophagus, but generally the GE junction is at, or the diaphragm is at 40 centimeters. It's amazing how reproducible this number is. And then I always want to know, where is the GE junction in relation to the diaphragm? I think you got to know the holes of the diaphragm. And, you know, I always ask my trainees, what are the 3 structures that go through the hiatus? And it's the esophagus and the vagus nerves. Through the aortic hiatus, what goes through there? The aorta and the thoracic duct, you know, this kind of thing. So these are important pictures to get a sense of. I do think you need to know the nerves and where they can be, especially if you're planning on doing trans diaphragm surgery. So this is important. What's really going on with the anatomy here? So there's the peritoneum, and there's the phrenoesophageal ligament, which is really peritoneum. So what is actually the sac? The sac is peritoneum. So I think that picture kind of shows that. As the stomach goes up, it's pulling the peritoneum up there. So that is the sac. So believe it or not, when you do these operations, you can pull the sac out and leave the other sacs intact. what are the other sacs? The pleura on one side and pleura on the other. So you can get that plane between the hernia sac, peritoneum, and the pleura and leave the pleural spaces intact. And once you do that, that's the key, that's the trick of these operations, to just pull the sac out and everything comes out. Now, here's a picture of a paraesophageal hernia, and I want to get a sense on the CT or endoscopy, how big is the opening? So, you can get a sense, you can measure it, and you get that sense on endoscopy. Okay, so if you have a super tight narrowing with a huge amount of content, that's at risk of ischemia, perforation. But if you have a wide hiatus with like a cone, pretty low risk of there being internal herniation. So this is kind of a nice picture of 1, 2, 3, and 4. And the difference between 2 and 3 is where's the GE junction at? 4 is when the vast majority of the stomach's up there and even pulling some transverse colon. I'm going to send this to you as well, too. This is a nice picture of the different types and what the barium swallow might show, and then what the endoscopy might show. On the type 2 lower end, that's a really nice one because you get the sense of that paraesophageal herniation on retroflexion underneath the scope, the thing that's labeled CII. And anybody with a giant hiatus hernia, I usually get a CT scan. In fact, I always do, because I need to know what else is being dragged up there, and is there any other surprises that I can get into? Because again, the bigger the herniation, the more you're doing a 2-field operation laparoscopically. So hiatus hernias, clinically, they can have reflux, sometimes not. And I say not because if you've got a big flop of an upside down stomach, you've got this V configuration and you don't get reflux. Bleeding, Cameron's ulcers. That's when the hiatus is moving up and down and it leads to erosion on the inside. And yeah, there's the obstruction, incarceration, strangulation, perforation thing. Diagnosis, chest x-ray is pretty good, but oftentimes people miss it. Radiologists don't, but in the ER, it can be missed. Barium swallow, CT, and endoscopy. These are obvious modalities. So here's a x-ray. And it looks normal to me at first, but then when you look at the cardiac silhouette, you see a round structure with an air fluid level. Same thing. This looks to be a gastrovolvulus with an upside down stomach configuration. There's a lot of herniation going on here. So that needs a CT scan. Barium swallow, you get the sense of where the hiatus is following the curves of the diaphragm. Again, there's the arrow, positive arrow sign. The top arrow is pointing to the para component, but I think that narrowed part lower down is where the hiatus is. And I can see where the GE junction is as well too. Upside down stomachs. CT scan with a hiatus hernia there. And in different, you get a sense of what's what in different angles. Yeah, here's a good one. Big hiatus hernia. And then you get the sense of it in endoscopy too, on retroflexion. And this grading scale, nobody uses, the author made this up, but you get a sense of where the hiatus is. Now, sometimes you can miss a giant hiatus hernia on endoscopy. And that's because if the hiatus is not super tight, and if it's big, as you get the scope in, you insufflate and you blow the stomach out of the chest. So it's not uncommon for an endoscopist to miss a giant hiatus hernia, believe it or not. But then you have to get a sense of the subtleties, where on retroflexion, you get a sense of what is that? Is that the hiatus? And when you breathe, the stomach rolls up and down. And you go, oh, that's the hiatus there. That's not just some weird band of the stomach. So again, it can be somewhat tricky. And here's a picture of the herniation. And what you do see with them breathing, it kind of rolls over it like that. So this looks like a big herniation, and one might say, hey, this is a sliding hernia, but that's when you inflated it with air. At the non-procedural component, there's a hole, and some of the other stomach may have gone up. So this is where you can maybe get fooled that, oh, this is just a slider, but it's not. So what's the treatment? What's the conservative management? You want to avoid binge eating and drinking. You want to recommend slow, frequent, and smaller meals. And, this kind of makes sense in the sense that if you're eating too quick and too fast, classic North American style, you just fill up the thing and people get short of breath. And if they say, hey, look, after belching or passing gas, after a while it feels better, then there's some obstructive nature to this. And certainly if they do have an obstruction, then they need to be admitted to hospital, IV fluids, and monitored, and NG and so forth. And they may need an urgent operation, obviously, if they've got evidence of ischemia. So who needs an operation? Well, obviously, emergent situation. If they are incarcerated and have some element of obstruction, then that needs an urgent operation. So symptoms, semi-urgent, well, if they have evidence of Cameron's ulcers or partial obstructions. And then there's this whole group of people, the asymptomatic giant hiatus hernia population. So I do see a lot of these patients where they have no symptoms, and somehow they've gotten a CT or a chest x-ray and they have a large hiatus hernia. So there's a lot of people, elderly, that have asymptomatic hiatus hernias. So older textbooks would say they all need to be done. And we're talking about older people, some with obesity and so forth. So, this all needs to be done thing is not how we do it nowadays. So if someone is truly asymptomatic, they can be followed with conservative management. And if there is any signs of obstruction or symptoms of early obstruction, then we reassess and then possibly do an operation. It's very rare for someone to have no symptoms at all and then to have an obstructive episode coming to the emerge with an undiagnosed problem. But that's what you try to avoid. That's what you don't want to see. So if someone is truly asymptomatic, I'm more likely to operate if it's a huge hiatus hernia, if there are other organs involved, for sure. And if it's a young patient, well, this is going to be a problem in their life. And again, I talk about the sac to neck ratio. If we've got a tight window with a huge amount of stuff up there, that needs to be operated on. And if I can't get my scope through it, if I can't get my scope through to the distal stomach or duodenum, that needs to be fixed in the sense that, hey, look, if there was a wide opening and I could get through it, blow the stomach out, and endoscopy, then they might not need an operation. But if at my scope, I'm stuck in the chest, tying a knot to my scope, trying to get out of the chest, that needs an operation. So these are the subtle things that you can see that forces your hand. So again, how do we do the surgery? Almost always laparoscopic. The key to this operation is pulling the sac out and taking the short gastrics down. You definitely want to take the short gastrics and pull the sac out, and then everything comes out. I want to repair the hiatus. I'm always amazed when people do these operations and they say they don't repair the hiatus. That's just weird. The question is, when do you need mesh or not? If a defect is 5 centimeters or less, it does not need mesh. 5 to 8, probably not. But once you get above 8 to 10, that's when people in textbooks and journal articles say it probably needs some amount of mesh. There are things called relaxing stitches that I say I really stay away from. quite honestly. That's where you make a relaxing stitch on the diaphragm to bring the true crust together and put a patch on that. The issue is you don't necessarily want to have mesh where the stomach esophagus are going to be rubbing up and against it, because it's thought that that'll erode, and it's probably true. You want to anchor the stomach to the repaired hiatus, and I always do a fundoplication because that's extra tissue to anchor underneath the diaphragm. So again, the abdomen versus the chest thing. Abdomen, what's the pros and cons? Well, you have access to the short gastrics. You're not entering the pleural space. You can do a full 360 Nissen. The con, well, the collis can be hard to do. We'll chat about that a bit further. And obesity can make a challenging operation. And if it's a two-field thing, you might have adhesions in one spot or the other, right? So in the chest, you can take down adhesions. Now, if something is stuck to the inferior pulmonary vein, if I'm going to injure it, I'd rather injure it while I'm already in the chest, not in the abdomen, if you know what I mean. And it can be difficult to stuff things down below the diaphragm. And I've always worried about trying to divide vessels like short gastrics, and you lose one, and you're in the chest and there's bleeding below the diaphragm. Well, then the answer is you do have to be in the abdomen. You can try and repair that through the diaphragm or a thoracoabdominal. So I thought I forgot this stuff. Short esophagus. Well, what's the definition? Well, we chatted about that. Is it short and scarred due to reflux? Or is it an anatomic variant? Or is it just tortuous and accordion because over all these years of herniation of the stomach, everything's migrated northwards? So what can help with this? Well, just by putting a bougie in, straightens it and pushes it down for you. So that's a good thing. You want to mobilize adhesions in the mediastinum to the lower end, not so far up that you're getting close to the inferior pulmonary veins. And you do want to bring the lower end of the esophagus down into the abdomen and anchor your wrap on the esophagus, and that goes below the diaphragm. So there's a lengthening procedure that's called the collis. So there's the thoracic collis or an abdominal collis. So if you're in the chest and you just can't stuff it down, you can, with the bougie in place, put a linear stapler, and that creates what's called a neoesophagus, say 3 or 4 centimeters of the stomach, and that's your neoesophagus, so you can get the bulk of the stomach to below the diaphragm. The trouble with this is that the esophagus has peristalsis, the neoesophagus part doesn't. So if this is not done correctly, you could give this patient dysphagia. So this is in a setting where you just can't stuff it down there. This can be accomplished through the abdomen in a very complex way. And this looks easy, but it's not. This is where you're using an EEA stapler to punch a hole in the fundus, and then using a linear GIA stapler to do exactly what we did through the chest. This is very challenging. Nowadays, in the situation where it's just not coming down, it's just easier to do the so-called fundic wedge, where you just remove that whole area. So this is where you remove that fundus with a staple line this way and then up, kind of like linear banding stuff back in the day for obesity, bariatric surgery. And then you do a wrap of some kind. So there are synthetic meshes, which I do like to avoid. There's biological ones, which I've been playing around with that seem to work. And this is from Sugar Baker's book. You can use pledgets, but the real concern for letter C and E is the fact that over time, the esophagus is rubbing right on that thing. And I like letter D, they have a relaxing stitch right over the cava. So I don't think anybody would do that. And there's a letter F is mesh at the front. So again, the hiatus has a teardrop appearance, and it's just easier to close at the back. But the trouble with that is, as you're closing it from the back, you're pushing your esophagus forward. So then, if you were to look at the anatomy, you're not straight anymore. Esophagus should be a posterior structure. So these are all the things I think about with these operations. Complications, and we all should know these. Complete disruption, it just all fell apart. I think that makes sense. So this is just a picture of the the wrap falling apart, but more commonly the hiatus falls apart too. There's the slip nissen, that's where your wrap is still intact, and then the esophagus over time, or the stomach, has actually slipped up through there. That's what's called a slip nissen. People get that versus the transhiatal herniation confused. The transhiatal herniation is where the wrap is still at the lower end of the esophagus, but has popped up. And this is the most common one that I see, a malpositioned wrap, where it's not anchored on the lower end of the esophagus. So this is anchored on the stomach. So the wrap should be anchored on the lower 2.5 centimeters of the esophagus, and then anchored to below the diaphragm. So then if you have a nice sutures to the hiatus, a nice wrap at the lower end of the esophagus, not just wrap, but through the fundus, wrap side through the esophagus, not into the lumen, but through the wall, then those are anchored. And then I have sutures from the wrap to the esophagus to the diaphragm as it's another further doorstop. So even with all that, I still have patients who do have recurrence of symptoms and or herniation. And I think anybody who doesn't say that probably hasn't done a lot or doesn't follow up on their own patients. I think these are obvious bottom lines. So we're going to take a break from that, and I'm going to unshare to answer some questions. And then I've got a very nice case, which is kind of cool, which I gave to the final year residents as a case. But it's something to think about, because you never want to be asked questions on an exam that you haven't been asked before. So let me stop sharing, and then let me look at the Q&A.
Dr. Lee, if you don't mind, we'd rather leave the Q&As at the end and
Sure.
go ahead with the scenario. That way, we can give the audience a bit of time just in case they have some questions regarding the case scenario. We have a volunteer. He's a senior resident, Dr.
All right.
Ahmadi. He's going to gladly take the case scenario that you've prepared.
This is like lamb to the slaughter. Dr. Omar, what's his name?
His name is Dr. Fahad. Fahad.
Dr. Fahad. Yeah. All right. So this should be fun. And again, Dr. Fahad, let me screen share.
Hello.
Hello.
Yeah, perfect.
Let me just close this one down. Okay, this is what I did last time, and I think this is helpful. So how do I examine people? Well, obviously I need to be fair, but I have to ask specific questions, because if I ask questions that are so open-ended, then you don't know how to answer and you feel bad about it. If a person isn't answering my question, I interrupt and ask them to answer my specific question. And it's not good to rush the candidate. You don't want to intimidate someone and then they say the wrong thing. And it's okay to redirect. And if I think that you really made a mistake, and I'll say, look, are you sure about that? and that's not meant to make you take back a correct answer. Okay. And it's really a chance for the candidate to be at their best. And it's okay to say, take a break, have a sip of water. So from your point of view, go over the scenarios. It's always easier to remember something than to make something up. Answer specific questions. Take a couple seconds. You don't have to answer right away. So if I ask you something, take 2 seconds to think about it, because if you just say something, it's probably going to be wrong. If you're asked to interpret something or you decide on a treatment, if the next question is based on a different treatment, it doesn't necessarily mean that you're wrong. It means that they want to ask questions about that other treatment. So it's not as if you made the wrong choice. And sometimes if a complication occurs, it's not you caused the complication. It's that they want to understand how you would manage the complication. It's not because you caused it. So if they say, well, now the patient has a leak, how do you manage that? It's like, oh my God, I did something wrong. And then you can't think anymore. Okay? So these are some of my tips. Of which there are many. So case 1. So you see a patient in the outpatient clinic, Fahad. She's 60, healthy, mildly obese, no other complaints, no past medical history. She has dysphagia and pain after eating, worsening over the last 6 months. So let's just say perfectly healthy, dysphagia and pain after eating, worsening over the last 6 months. So what further questions might you ask this patient specific to her GI system?
So I would start my questioning about the symptoms, whether it is related to opposition or not, how long does it persist, the severity of the symptoms, and is there any similar family member with the same symptoms? And then I would ask if she had encountered the same symptoms before or not.
Okay.
Is it related to liquids, to solids?
Good point. Yeah. So after further reflection, she says, it's after I eat, I have pain and I have trouble breathing. And then it seems to be relieved when I give a big burp. And also, my stools seem to be softish. They're brown. They're not black. Any blood work you might want to order for this patient specific to her GI system?
So I would start with complete blood count, coagulation profile. I would go for stool occult blood, renal function, liver function tests.
Sounds good. What tests might you order at this point in time?
The easiest I can get is an X-ray, maybe. X-ray, endoscopy, or even a barium swallow.
Sounds good. So this is the X-ray. Could you describe this X-ray?
Yeah, I can see there is a stomach bubble in the chest, or at least a gas bubble in the chest.
Okay, what do you think that is?
Most likely herniated stomach.
Here's the barium swallow, and what do you see here?
So the patient has a hiatal hernia, most likely a Parasocial hernia, with the stomach herniated. Yeah, most likely Parasocial hernia.
Okay, is there obstruction?
There is incomplete obstruction, yes.
Very good. There's no complete obstruction. There's contrast at the bottom part. CT scan confirms your thought that there's a parasophageal hiatus hernia. So what's your diagnosis? You said it already. So what are the different types of hiatus hernias?
So it's 4 types, starting with sliding, parasophageal, and then parasophageal with of the cardia or the fundus herniated, and then the whole stomach herniated with part of the any abdominal organ.
Perfect. Now, with respect to her parasophageal hernia with obstructive type symptoms, what medications might be helpful?
For parasophageal hernia with partial obstruction, I would proceed with surgery. I would start her on PPI at the start, and then most likely I would proceed with surgery.
Do you think a prokinetic is going to help the situation, like a Maxaran or domperidone?
I highly doubt it. No.
Okay. And okay, you said surgery. So what are the different approaches to surgery? So what are your options? What are your options at this point?
Okay, so I have to reduce the hiatal hernia, and then I have to perform a Nissen or tope fundoplication. It's like either abdominal or thoracic, of course. But yeah, either abdominal or thoracic approaches.
Okay, what would you choose?
I would go for abdominal.
And then laparoscopic, open?
Laparoscopic, abdominal.
What's your conversion to open quote?
Very low.
Okay, the patient says, what's that mean?
Okay, so the conversion to open from laparoscopic repair is very low. If we encounter some complication or difficult anatomy, there's adhesions.
Perfect. How would you consent this patient based on risk, benefit, and risks of likely complications and risk of severe, albeit rare, complications like death?
Yeah. So I would start with explaining the procedure to the patient, and then explaining the indication that I'm going to be performing the procedure for her, with letting the patient know that there's a complication that could occur, such as some patient could get dysphagia, and others would get a herniated rab or disrupted rab. Also, a pneumothorax is possible. Some patients would require a redo surgery, and some patients would require a bypass surgery.
Okay, you do an endoscopy.
Yeah, of course, leak and bleeding is like one of the complications that I did not mention.
Of course,
injury to adjacent organs. Yeah.
So at endoscopy, what specifically are you looking for? Like, what do you want to see on the report if someone else did it?
So on endoscopy, I would assess the esophagus, the mucosa of the esophagus, making sure there is no Barrett's esophagus, and assessing the stomach for any ulcers.
Perfect. So you're planning out your operation now, Dr. Fahad, and your anesthesiologist is new. What monitoring should they do in terms of, do they need an art line? Do they need central line? What you're telling him or her what they should do for their component?
Monitoring the vitals and arterial line are necessary. Keeping an eye on the monitor of the patient, making sure that she doesn't develop any sudden tachycardia or bradycardia or hypotensive.
Perfect. And do you do an endoscopy at the time of the operation? You've already done one last week. Do you need to repeat it?
Well, usually no, we don't.
Now, you're in the middle of your operation. The patient does have an art line in. They're fully monitored. And I'm not sure if you told them to put a central line in or not. You're working up in the hiatus and it's stuck anteriorly. So when you're working in the hiatus, there is, heading north, there's a floor, there's a ceiling, and two walls. What structure is at the floor? What structure is at the ceiling? And the lungs are the walls. So what's the ceiling and what's the floor?
So we have the second pleura. They might have injured the pleura there, and the patient might have developed a pneumothorax.
Okay, but specifically in the hiatus tunnel, what anatomically is above the esophagus and what's below the esophagus?
So, I mean,
they're both pulsatile.
the aorta and IVC.
Okay. Anterior to the esophagus is the heart. So you're working up in the hiatus anteriorly, and things are stuck. And this is all laparoscopic with a pressure of 15. You're working your way, and then immediately the blood pressure drops, and the patient's tachycardic. Now, you mentioned pneumothorax already. What else could it be other than pneumothorax?
Major vessel injury.
That's very, very good. There's no bleeding. There's no bleeding that you can visually see.
Cardiac injury.
Very good. So if you were to have a hole in the pericardium and you're laparoscopic, you're doing this laparoscopic with the pressure in the abdomen, what clinical syndrome is happening to the heart?
What clinical syndrome is happening to the heart? I surely know it. I think cardiac tamponade.
Very good. So cardiac tamponade. So you mentioned already tension pneumothorax. That's possible, and cardiac tamponade, and there's no bleeding. So what do you do now?
Convert to open.
Very good. So you convert to open because, as you know, the pressure, you can't keep on with this operation. It's the pressure from laparoscopic surgery. And no, you can't fix the hole. Yeah. So you do it open, you go, oh, we got to open. No big deal. So you do need to know what pulsus paradoxus is, and you know what to do when you open. So things are still stuck in the hiatus, especially on the left. On the left, you're working your way up now. You're working your way up in the hiatus. So you're in the abdomen. You're working your way up in the chest to the left side. And now there's a lot of bleeding now. So you're using your harmonic or your ligature, you're dissecting something, and now all of a sudden there's an explosion of red blood. Bright red blood. What things could be injured up in the hiatus, the left chest now, that could bleed red blood?
Did I injure like the lung or intercostal vessels?
That's possible. What else? It's a lot. It's pouring out.
IVC?
That's on the right.
Yeah. Or the aorta.
Aorta. Okay. And the inferior pulmonary vein also. Mm-hmm. So now you've got a lot of bleeding. You immediately pack. The injury is about 8 centimeters above the hiatus. You pack it, and then now what?
Perform a left anterior lateral thoracotomy.
Perfect. So there's a hole in the left inferior pulmonary vein. You fix it. Another complication that you fixed. The patient's stable. It's not a damage control situation. What do you do about the hiatus hernia now?
So I would reduce the hiatal hernia and dissect the sac.
Perfect. So, the problem here is that the hiatus hernia was stuck in the chest and it needed a direct dissection anyways. So since you're now in the chest and a hole in the belly, you can just carry on with your operation. It's not a damage control situation. You free up the hiatus, push everything down, and then do the repair either through the abdomen or the chest. It doesn't really matter at this point. Really, this is an exam question really about not just complications of laparoscopic surgery, but complications of hiatal surgery. So again, there's pneumothorax, tension pneumothorax, and injury to the pericardium, and insufflation-induced cardiac tamponade. So, Dr. Fahad, fantastic! You did a fantastic job on this little.
Thank you so much. Yeah, thank you.
My pleasure. So let me unshare.
All right, Doctor. I think we can proceed to the Q&A.
Yeah, can you moderate, Omar, and or do I open? Yeah, why don't you moderate?
You can go ahead and read the questions that you'd like to answer, assuming they're relevant to the
topic, I see.
Or the ones that you would like to answer.
I'll try to answer them all. A question on home remedies. I'm not really sure about home remedies. Belching is a problem, right? There's all kinds of psychiatric medications that people try for this kind of stuff too, but I really couldn't comment on belching. How does air get into the stomach? It's air swallowing. I used to think that air, when you digest, the breakdown of stuff created air. It's the air we swallow. So, when I drink my water, very little air goes down, but when I drink pop, a lot more air is going down. Same thing with popcorn and little stuff like that, right? So I just say to patients, just be very mindful of how you eat. In my opinion, which PPI is better, Nexium or Losec? I don't think I would have a comment on that, but I do think that Dexilant, and this is maybe just marketing or the fact that it's the most expensive, I think, and I see it, that Dexilant probably is the best. So as far as I'm concerned, when I'm dealing with someone with refractory reflux, I'll put them on Dexilant at the highest dose BID and see what happens, and then work my way backwards. And if they say, hey, like that helped, great, then I might lower the dose and see what happens then. But certainly if they're refractory to high dose Dexilant and or a motility agent, then that's when I'm thinking of surgery. The motility agents are not great. They're not specific to the stomach or the esophagus for that matter. Some people benefit, some people don't, but we try it and it's pretty inexpensive. But really, as far as PPIs go, I think they're all the same, but I do think that Dexilant is the best. Okay, I like this question. Management of echolasia, myotomy versus esophagectomy. This is a good one because we had the same discussion in our group here. Now, what does surgery accomplish for echolasia? Echolasia is where there is a lack of peristalsis and the lower esophageal sphincter doesn't relax when food is supposed to get there on time. So we can't hardwire the esophagus any better. All we can do is improve emptying by gravity, by loosening the lower valve. So if you can loosen the lower valve enough so that there's better emptying, then that works. And that could be accomplished with a Heller myotomy or a POEM. Again, if there is a hiatus hernia or you're fearful of reflux, then I would be doing a Heller and Door, not a POEM. So if someone has a hiatus hernia, I personally think that is a contraindication for a POEM. And yes, if you do a POEM, then someone could do surgery beyond that. But as far as I'm concerned, you want to have one operation, one procedure only. With respect to esophagectomy, well, again, in echolasia, if the esophagus is straight, then you can do an outlet procedure. But what happens if this has been going on for years and years and years, and you have a dilated esophagus? Well, if it's dilated and straight, that'll empty. But if it's so dilated and tortuous and a big flop heading over to one side then down, nothing at the GE junction is going to help that. And it's worse when it's so dilated that part of the esophagus is inferior to the hiatus and GE junction proper. So that won't drain at all. So that needs an esophagectomy for sure. What procedure would you proceed with colitis in obesity? Good point. So with respect to when someone does have really bad heartburn and a hiatus hernia, I think you can fix that with an anti-reflux operation if they have evidence of delayed gastric emptying and they're a candidate for bariatric surgery. I do think it's important to fix the hiatus hernia and then to have a bariatric surgeon provide an opinion. And yeah, dealing with doing a bariatric surgery could improve reflux for sure. But you better emptying. Like a combination of both. And yeah, if someone has gastroparesis, then I do like to try something at the gastric outlet, knowing that, hey, look, this isn't really going to work. So the stomach should, kind of do, well, my pictures are reversed, but the stomach should look like an L. Okay. And when someone has really bad gastroparesis over years, the stomach dilates. So you have this giant thing. So similarly, if the stomach is so giant and has kind of expanded this way, and it's not peristalsing, and the lower part of the stomach is below the antrum and pylorus, that's not working, it's not going to drain very well. You can lean like this after you eat for hours if you want, but that's not a way to live. That's when you probably do need to think about a bypass procedure, a RU. I saw a question on how to manage esophageal perforation. That's a talk in and of itself. It gets complicated when in the setting of an attempted hiatus hernia operation. So in terms of managing a Borhaves or a malignant perforation or something, that's a different topic, but similar. If someone is doing a redo esophageal hiatus surgery and you have a perforation, then you have to fix the local defect, which is almost always a 2-layer repair. So if there's normal looking tissue, then you want to do a mucosal repair, which commonly I use, say, a 2-0 or a 3-0 vicryl interrupted, and then also a muscular repair. And classically, the mucosal defect is bigger than the muscular repair. So you need to extend the muscle injury just to see the mucosal defect. And then once you've done that, then you can repair that. And I always do this as a 2 or a 3-0 vicryl interrupted. And then with respect to the muscle layer, I always use a 2-0 silk. And then you buttress the repair. You support the repair with something else. So if you're in the abdomen and you've got a little defect to the lower end of the esophagus, omentum is sewn right on. And sometimes you can bring omentum from the abdomen into the chest to support that repair. If you're in the chest, you can use you can use the fat that's sitting on the pericardium. You can use an intercostal muscle bundle that you've harvested on entering the chest. You can sew diaphragm right on top of it. You can sew pleura on top of it. So it's like the 3rd layer. And if someone has had a perforation and I want to really protect it, I'll put an NG above the repair site and do a G tube to drain acid and a J tube for feeding if it's a really bad thing. Let me I think I skipped some questions. Let me close that one up and see. Oh, that's Dr. Isa saying hi. Oh, here we go. I'm not sure what strata is. There's all kinds of there's endoscopic approaches, which hasn't really taken on. There's these magnetic beads and so forth, and prosthetics. I think all that is not fully tested as much compared to the standard operations. The real concern with prosthetic devices and the beads, the magnets, is that, well, could that possibly erode over years? And sure, it was tested over a small amount of time, but when we even think about mesh at the hiatus, these are people who might erode 10, 15 years down the line. And those are the kind of people that I see. And I get a lot of these patients who, as a cardiothoracic surgery guy, I get a lot of gastric surgery patients who have had prior linear banding and where the mesh has eroded. And, I'm doing the resection for that. As thoracic surgeons, we tend to be the experts in gastric surgery now. So at least in Canada, where I was in Ontario and then now here, I do a lot of those type of revisions. Typical symptoms of reflux. So, in terms of the typical symptoms of reflux, I think when someone is seen by their general practitioner, what would they do? They would start to PPI and counsel on lifestyle modification. And then if that in and of itself didn't control the symptoms, then a referral to a gastroenterologist would be made. But then there's a delay to that. So then they would be scoped and then their reflux would be quantified, and increase or alteration of medications might be tried. Once you start getting into the complexity of, well, what's going on here? Is it a nocturnal thing? Then that's when the gastroenterologists think about doing a 24-hour pH study and or motility to try and really understand what the esophagus and stomach are doing and what could potentially be done about it. And I said it before that as a surgeon, that's getting a bit beyond what I normally do. And in 2021, I'm happy to accept referrals for hiatus hernia from anybody. But with respect to reflux, I'm doing an operation which isn't a perfect operation. I'd rather them be optimized and sorted out by gastroenterology first. So, that's what my preference is. I would not want to get a lot of refluxers from family doctors, because then, it occupies a lot of my time working them up, seeing them in clinic, when as a surgeon, I need to be working up surgery. So as surgeons, don't feel bad about, deferring to your gastroenterologist. And I think the biggest key for reflux is I don't fight with gastroenterologists. I don't get in debates of medicine versus surgery. I think there's a continuum in the sense that, medication's obviously first, and if they're refractory, then we think about a surgery. And and always do I get consensus with my referring gastroenterologist. I don't see it as a competitive thing.
I think that concludes our last question. And with that, we reach to the conclusion of our session. Thank you very much, Dr. Lee, for this wonderful and extremely informative session. And I'd like to thank our senior resident, Dr. Fahad Hamadi, for his participation in the case scenario. And a reminder for all our lovely audience to follow us on our social media platform for our next session, which will take place next week and on Sunday at the same time. And I'd also like to thank our lovely audience, for whom without them, we would not be here. So thank you, everyone, and looking forward to see you next week. Thank you, Doctor.
Thank you very much, Dr. Omar, Dr. Mohammed Jamal. Thank you very much, and to all in the audience, it's been a great, a lot of fun for me, and have a great rest of the evening.
You too, Doctor. Take care.
Bye now.